The backstory. What to actually say to your patients. Written by Julia Gover. This summer, I was watching my two children running around the garden with their cousins. They don't see each other very often, so there was a lot of energy, a lot of noise, and a lot of chaos. And a lot of joy. And as I watched them, it struck me that I could describe exactly the same scene in a few very different ways. I could say they were a group of children, or a gaggle of mischief makers, or a gang of youths. Nothing about the behaviour changes, but the words I choose to tell you a lot about how I feel and what's happening in my garden. And it's exactly the same when we talk to patients about pain. The chronic low back story. Chronic low back pain is associated with disability, work absence, unemployment, and high healthcare use. Quality of life is often dramatically reduced. In one study, people with chronic low back pain reported quality of life scores comparable to patients receiving palliative cancer care. Despite chronic low back pain being highly prevalent, it is still widely misunderstood. Large proportions of the general public believe back pain is caused by injury or damage, that bed rest is the best treatment, and that once you've hurt your back, it will never be the same again. What's more concerning is that these beliefs are also common among healthcare professionals. And that matters, because clinicians play a major role in shaping how patients understand their pain. We often talk about challenging patient beliefs so they can engage better with treatment, but inaccurate beliefs don't just affect behaviour. Inaccurate pain beliefs can increase threat, and increased threat increases pain. Research shows that when clinicians deliver strongly biomedical messages, patients develop hypervigilance, more fear, and more disability. These patients often feel guilty if they can't follow advice perfectly, and even when they do everything right, pain flares can feel baffling and demoralising. In contrast, when clinicians provide accurate reassurance and encourage movement and confidence, patients report higher self-efficacy, greater activity levels, and better engagement with life. Not just exercise, but meaningful activities and social connections. Pitfalls in pain science. Most clinicians can confidently define acute and chronic primary and secondary pain, or tell you the difference between pain etiologies like nociceptive, neuropathic, or nociplastic. But even with this clinical knowledge, there are some common pitfalls that clinicians can fall into when forming their own beliefs about pain. Pitfall number 1. Acute pain goes chronic at 3 months. Acute pain is defined as pain that's been present for less than 3 months and is more likely to be associated with nociception. Chronic pain is defined as pain that lasts longer than 3 months. Pain doesn't magically change character at 2 months and 29 days. With that time frame reflects is two things. The time most tissues take to heal and the point at which number of neurological mechanisms that can maintain pain tend to become established. That 3-month mark isn't arbitrary, but it also isn't a hard line. Not only that, but some chronic or persistent pain syndromes occur in the absence of an initial acute injury, and some are a result of ongoing nociception from a chronic disease. Pitfall number 2, that some pains are biological and some are psychological.